Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Roche.
Hello, I'm Arshad Kanani. I'm a retina specialist based in Reno, Nevada, USA. Welcome to this activity, Pearls and Retina Biomarkers for Clinical Practice. It's my pleasure to be joined today by my friend and colleague, Stella Vjozovic, a retina specialist based in Milan, Italy. Welcome, Stella.
Thank you, Arshad.
I'm looking forward to our discussion. There's a lot of buzz about biomarkers in retina these days. We are going to try to make sense of this for you and to keep it focused where we are going to answer questions against the clock. Are you ready, Stella?
Yes, of course.
Let's get started. So the first question is for you, Stella. It is, what do you mean by a biomarker in the context of retinal disease?
A biomarker is a defined characteristic that is measured as an indicator of normal biological processes, pathogenic processes, or responses to an exposure or intervention, including therapeutic interventions. They can be diagnostic, monitoring, pharmacodynamic, prognostic, predictive, safety, susceptibility. Biomarkers have an important role in clinical research as they allow for smaller in size and shorter clinical trial duration for regulatory approval. However, we need to bear in mind that a correlate does not a surrogate make and that biomarkers need to be validated as surrogate endpoints. What we need in clinical practice of retinal diseases is to be able to evaluate our patients in an easy, non-invasive, and reliable manner with multimodal imaging. In this context, the use of non-invasive imaging biomarkers that are easily captured in the office and allow for objective and fast evaluation is increasingly important. Imaging the retina with high-resolution techniques has advanced our understanding of its complex anatomy, function, and pathophysiology, and in addition, AI could help us in more precise detection and quantification. The increasing use and understanding of imaging biomarkers, supported by the clinical evidence, will enhance early diagnosis, treatment decisions, and response evaluation in retinal diseases. Arshad, a question for you. When assessing patients with neovascular AMD and DME, what imaging features do we already use as biomarkers?
Stella, that's a great question. As you know, most of you watching this already use biomarkers every day in your practice. And Stella, you and I both are looking at central subfield thickness, which is a measurement we get on OCT, used a lot in clinical trials to look at efficacy and disease control. Then, of course, in clinical practice, we're paying a lot more attention to the compartments of fluid. Intraretinal fluid, which is an important marker of disease activity in neovascular AMD, as well as DME. Subretinal fluid we see in neovascular AMD also is a biomarker for disease. And pigment epithelial detachments are important. There are different kinds of pigment epithelial detachments, serous, fibrovascular, and I think we can gauge the treatment response based on flattening of pigment epithelial detachment when you're using a treatment. Stella, I have already mentioned intraretinal fluid. Why is resolving intraretinal fluid so important in treating retinal disease? And you got 90 seconds.
We all look at the intraretinal fluid as it is an important marker of disease activity if we think of neovascular AMD, DME, or macular edema due to other retinal diseases. It is usually associated with worse visual acuity when compared to subretinal fluid, and it is also associated with the thinning of the ellipsoid zone of the photoreceptors. It can be also considered an exudative biomarker associated with macular neovascularization type 3, and its volume indicates short-term visual outcomes in type 3 macular neovascularization, reflecting the negative effects of intraretinal fluid on neuroretinal structure. Neovascular fluid can be associated with subretinal hyperreflective material and hemorrhage that can lead to fibrosis. A recent post-hoc analysis of the VIEW 1 and VIEW 2 trials showed that increasing duration of intraretinal fluid exposure was associated with lower visual gains and less improvement in vision-related quality of life in patients with neovascular AMD. And this is the same also for DME patients. So the post-hoc analysis of Yosemite and Rhine trials showed that greater intraretinal fluid reduction after one single injection was associated with improved outcomes at 1 year, and also greater intraretinal fluid reduction after 3 monthly injections was associated with better visual acuity outcomes at 2 years. Arshad, the question for you. We agree that resolving intraretinal fluid is important, but do we have clinical data on comparing our anti-VEGF drugs against intraretinal fluid?
That's a great question. As you know, as I mentioned, in clinical trials, usually we get the central subfield thickness, but some of the trials have also shared the intraretinal fluid and subretinal fluid improvements with new treatments. When you look at the available treatment, we don't have any data comparing faricimab versus aflibercept 8 milligram, but we have data for faricimab and aflibercept 8 milligram compared to 2 milligram. When you look at the phase 3 Tenaya Lucerne studies in neovascular AMD, there was a greater CST reduction in the managed dosing phase with faricimab compared to aflibercept 2 milligram, and that benefit stayed and increased after monthly injections. When you look at absence of intraretinal fluid and subretinal fluid in the head-to-head loading phase, where we can compare the drugs very well, what we saw was more patients achieve a dry retina with faricimab versus aflibercept 2 milligrams during the head-to-head dosing phase in Tenaya Lucerne study. And when you're looking at DME in the pivotal Yosemite and Rhine studies, what we see is that the median time to first absence of intraretinal fluid achieved with faricimab more than 9 months faster and with fewer injections compared to aflibercept 2 milligrams. And when you look at the absence of intraretinal fluid over 2 years, more patients achieve absence of intraretinal fluid with faricimab compared to aflibercept 2 milligrams through year 2. Now let's look at the data from aflibercept 8 milligram compared to 2 milligram. We saw no difference in CST between those two agents in the PULSAR study in neovascular AMD, and we saw no difference in CST between aflibercept 8 milligram and 2 milligram again in DME in the PHOTON study. So the bottom line is that targeting VEGF-A as well as Ang2, the dual inhibition with faricimab, appears to improve intraretinal fluid and subretinal fluid and CST better than aflibercept 2 milligram. Now, Stella, what about macular leakage as a biomarker? And do we have comparative data on macular leakage in patients with diabetic macular edema?
Thank you, Arshad, for this question. Macular leakage is associated with the development of DME, and reduced macular leakage correlates with improvements in vision and anatomy in people with DME. For example, if you think of the RUBY phase 2 study, it showed that greater reduction in macular leakage area correlated with improved anatomic outcomes, including less intraretinal fluid and lower microaneurysm count, and also better best-corrected visual acuity. And in the phase 3 Panorama study, increased fluorescein leakage area at baseline was associated with an increased risk of developing vision-threatening complications and/or center-involved DME among sham-treated patients. So macular leakage may be an important biomarker for blood-retinal barrier function and vascular stability. In the PHOTON trial, no clear evidence of better control of leakage with aflibercept 8 mg versus aflibercept 2 mg at 12 weeks was shown. In terms of data on macular leakage with other drugs, for example with faricimab, faricimab showed improved resolution of macular leakage versus aflibercept 2 mg at week 16, and with fewer patients had high macular leakage, more patients had resolution of macular leakage, and average size of leakage area was reduced by 53%. So these data suggest that dual inhibition of Ang2 and VEGF-A may promote vascular stability beyond the effects of VEGF alone.
Stella, that was a great overview of macular leakage. Now, we know that inflammation is an important process in retinal disease. Is there a good biomarker for inflammation?
Definitely, and we are, I would say, lucky that we have this multimodal imaging with which we can evaluate novel imaging biomarkers of inflammation. If we, for example, think of OCT, we can definitely evaluate the hyperreflective foci, which are the signs of the activated microglial cells, thus the inflammatory retinal response. We can evaluate all other different parameters, such as, for example, the presence of subfoveal neuroretinal detachments. We can evaluate retinal cysts for the location and the size, and also we can evaluate the disorganization of the inner and outer retinal layers. If we think of hyperreflective foci, we know that a lot of retinal lesions can be seen on OCT as hyperreflective foci, but those that are sign of inflammation are definitely the activated microglial cells. Data from the literature clearly show that hyperreflective foci decrease with the treatment. However, we still do not know if the number of hyperreflective foci can predict the treatment outcome. And also the post-hoc analysis of Yosemite and Rhine protocols showed that there is a greater reduction in the volume of hyperreflective foci after treatment with faricimab versus aflibercept 2 milligrams. Another sign of inflammation, for example in DME, is the presence of subfoveal neuroretinal detachment, and this pattern of edema has been correlated with higher levels of interleukin-6. And Arshad, what about PED improvement? Can that be a marker for greater and faster drying?
Thanks, Stella. That's a great question. I've had long-standing interest in pigment epithelial detachment, and as we know that PED improvement is a marker for anatomic and vision improvement in neovascular AMD based on published literature. But PEDs are less responsive than some other biomarkers to traditional anti-VEGF agents. Now, in terms of looking at the data from the next generation anti-VEGF agents on PED, we have published data showing that greater reduction in PEDs and sub-RP fluid thickness with brolucizumab was seen more than aflibercept in the Hawk and Harrier trials. And when you look at faricimab, we have seen greater reduction in maximum PED thickness and fewer remaining serous PEDs versus aflibercept 2 milligram in the Tenaya and Lucerne studies. And we have also seen the faster time to 50% reduction of maximum PED thickness with faricimab versus aflibercept 2 milligrams. And we have not seen any data on PEDs from the aflibercept 8 milligram trials, but I'm looking forward to that data.
Arshad, again, are there any imaging features that can predict the risk of developing fibrosis in the long term?
Thanks, Stella. Of course, fibrosis is an important point. Many of our patients with neovascular AMD develop fibrosis and lose vision over time. Of course, in clinical trials, it's not a biomarker that gets measured because many patients with large hemorrhages are excluded. And as you know, subretinal hyperreflective material as well as subretinal hemorrhages can lead to fibrosis. When you look at fibrosis in terms of clinical practice, we have seen several different things. When we look at brolucizumab, we have seen greater reduction in subretinal hyperreflective material compared to aflibercept in neovascular AMD. And we have seen correlation between absence of subretinal hyperreflective material and thinner subretinal hyperreflective material with better vision outcome based on the work we did from that trial. And looking at faricimab, we have seen better resolution of subretinal hemorrhages in eyes that were treated with faricimab based on our Truckee study where we have analyzed patients in a real-world setting, and these patients, many of them had hemorrhages, and 75% of eyes actually had very quick resolution of hemorrhages after treated with faricimab. Now, when we look at diabetic macular edema, epiretinal membrane is also a part of fibrosis spectrum. And an analysis of Yosemite and Rhine data showed that patients treated with faricimab actually developed less epiretinal membranes compared to patients who were treated with aflibercept 2 milligrams. So it's an evolving story. We know that Ang2 inhibition can be antifibrotic in the preclinical model, but I think we don't have evidence in randomized control studies in terms of looking at that because it was not evaluated. But the real-world data clearly shows that we may be impacting the formation of fibrosis, but more work is needed. Finally, Stella, perhaps the most important question is, how to bring these data from the research setting to patients. How can our audience use biomarkers in clinical settings? Do you have any pearls for them?
I agree, this is the most important question. So how to use the biomarkers in clinical practice? We should definitely use them in our everyday clinical practice because they can help us in the diagnosis of the disease, in the evaluation of progression and assessment of treatment response. Imaging biomarkers of the retina obtained with the modern instruments could advance our understanding of complex pathophysiology of the retina in different retinal conditions. For example, if we think of neovascular AMD, you showed us clearly about intraretinal fluid, subretinal fluid, PED, or subretinal hyperreflective material. In DME, we have a lot of parameters we can evaluate besides the central retinal thickness, such as, for example, the hyperreflective foci, the retinal cyst, intraretinal fluid, subretinal fluid, integrity of the inner and outer retinal layers. As we know, the DME has a complex interplay of microvascular modifications, neuronal and glial component in the retina. So all these parameters represent a potent set of tools to be used in everyday clinical practice that could help us in more precise diagnosis of retinal disease, enhance the treatment decisions and response evaluations. Far from serving only for the research purposes, the non-invasive imaging biomarkers should be introduced into clinical practice on a daily basis, and in addition, AI tools can precisely quantify them, thus support us in the management of patients. Therefore, I think that all retinal community should become familiar with all the imaging biomarkers we have mentioned today and use them in everyday clinical practice.
Stella, that was a great overview. So here are the key takeaways from our discussion today. We all use biomarkers every day in managing neovascular AMD and DME. New biomarkers are also useful, and we are evolving towards using them in our clinical practice. Looking at macular leakage, we can look at durability of a treatment, looking at epiretinal membranes, which is a marker for fibrosis. We also have other biomarkers that we discussed today, hyperreflective foci in patients with DME, pigment epithelial detachment, as well as subretinal hyperreflective material that we can use to manage our patients to optimize treatment. Stella, I really enjoyed speaking with you today. Thank you for bringing your expertise.
Thank you, Asha, for inviting me, and I'm really glad to see that we both agree on the importance of the use of biomarkers in clinical practice.
And thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.